Now, I must put a little bit of a warning on this talk. There are some very nasty wounds. I mean, you've come to a wound care conference, so I'm assuming you understood the risk, but there are some quite confronting wounds in this talk. A lot of them have been my patients, and they've all consented to have their photos for this and their stories told. But I do like to just give you a little bit of a heads up, okay? Because you can't talk about malignant wounds without talking about the nasty, okay? And they are nasty. You'll often hear, who's heard the term fungating wound? And it's used a lot with this, and it's not a good term to use with malignant wounds, really, because they can fungate and they can ulcerate. They don't just fungate. There's lots of different nasties with this. So fungating is not, it's an all right descriptor for certain types of malignant wounds, but malignant cutaneous wound is what you really want to use. And especially if you're looking at the literature, you want to look at malignant cutaneous wounds, not fungating wounds, okay? And I'm fortunate enough to work at St George, and I've worked at St George now for 18 years, and it's just been a wound care roller coaster for me because if you want to be a wound nurse, it's a place to be. We've got a massive cancer service at St George, a massive cancer service, and doing very cutting edge cancer surgery as well as cancer treatments, including radiation oncology. We've got a massive trauma service. We're the trauma centre everywhere south of the bridge to Milton Ulladulla. We've got a big surgical service. We've got a big aged care service. So I get to see all these different types of wounds and see what works and what doesn't. Apply things from trauma to malignant, from aged care to trauma. It's a melting pot. So we do get these wounds, and unfortunately we get them pretty frequently. In the last month I've seen 6 malignant wounds, which is unusual, which is quite a high amount for me. And the majority are breast cancer. I'll use this because I like to wander. One of my wound care heroes, Gary Sibbald, actually it was his talk that got me into wound care more so than just having a passing like for wound management. I heard him at the Australian Wound Management Conference in Tasmania. And it's the saying, you've probably heard it, treat the whole person, not the hole in the person. A lot of my calls for wound management is what dressing do I put on this mat? Generally my answer is I don't care, tell me about your patient. I can tailor the dressings, I don't care what dressings you've got, I'll tailor your dressings to the patient. I want to know about the patient. Okay, we need to treat them holistically and not treat them as a piece of meat. So some key points. For a significant minority of cancer patients, the presence of a malodorous, exuding necrotic skin lesion can be a constant physical reminder that the disease is both progressive and incurable. So if you see this patient, they've got a malignant wound, every time they see it, every time they smell it, every time they feel it, it is a visual, it is a reminder that they are going to die. We don't fix these. We don't. We can put it back with radiotherapy, chemotherapy, we can shrink it, surgery sometimes, but in my experience, they always come back. Always. So it's frightening. It makes an already scary situation more frightening for this patient. So if you're not empathetic to your patients in their end-of-life condition, you should be more so when they have a malignant wound, because they can be awful. Fungating wounds may develop from a primary skin tumour, an underlying tumour, or metastatic disease. Sometimes a chronic wound may undergo a malignant transformation to produce a malignant wound, although this is rare. The most frequently reported symptoms related to malignant wounds are malodour, exudate, bleeding and pain. So fungating. So malignant cutaneous wounds are a significant challenge for the palliation of a patient. Unlike other wounds, symptom control is often more the primary focus of management. Just coincidentally, I'm actually in the process of writing a paper on palliative and end-of-life wounds with my colleagues at St George. We're doing an integrative review into the last 10 years of palliative wound management. And interesting things I've learned off my palliative care colleagues is the main difference between end of life and palliative care. Okay, not many people see there is a difference, but there's a definite difference between palliative care and end of life. End of life, your patient, I don't really like this term, but your patient is actively dying. Palliation can go on for years. And many patients in our aged care facilities, you are palliating. Okay, you're preparing them for death. That's what you're doing. So, and often with wound management, goals are sort of often forgotten sometimes, and when we're looking to pick a product. And often our goal is unrealistically set at wound healing. Now, as a wound care nurse, I've never healed a wound in my life. I've helped a patient heal their own wound. I've helped them. I've facilitated their healing, but I don't put skin grafts on patients. I don't revascularise limbs. I just help people. I'm a nurse. I work with my patient to help heal themselves. But in this case, in a malignant wound, what we're doing is wound management the majority of the time, not wound healing as a goal. And that's a really important goal to set. We are managing this wound. We are not trying to heal this wound, because we won't heal it with our dressings. The radiotherapy may shrink it, the chemotherapy may shrink it, but our wound care, our wound management is just going to be at symptom management, basically, for these patients. So malignant wounds usually have a poor outcome. However, surgery, chemotherapy or radiotherapy when used to treat the underlying disease process may assist in controlling a malignant cutaneous wound. I had a breast cancer lady recently who had her breast cancer for 15 years, and she had her malignant cutaneous wounds after 2 years. And with radiation therapy and chemo, they went away for 4 years, but they came back. And she was always scared of them coming back. She was frightened of them. Even when they weren't there, she was frightened that they would come back. So the term fungating refers to a malignant process of both ulcerative and proliferative growth. Lesions that have proliferative growth pattern may develop a nodular or fungus look or a cauliflower-shaped lesion, whereas a lesion that is ulcerating will produce a crater-like lesion. In my experience, ulcerating malignant wounds are worse than the fungating ones, because normally they erode away to a blood vessel and your patient bleeds out. This is from a cancer of the optic nerve, and these are awful. These generally eat through very quickly to the brain. It's very, very nasty cancer. And again, imagine how this man feels. You know, because we're all making faces when we're seeing these pictures, but we're also making those faces when you see the patient for the first time. And unfortunately, I've seen people not prepared for it at handover, because the nurses want to giggle at the reaction of the other nurse when they first see it. How do you think the patient feels about that? That's horrific. Okay, it's not often, thank goodness, but it does happen. And someone is already feeling awful. It's not our job to make them feel worse. Here's a big list for you. I'm going to do you the courtesy of not reading them all. The PowerPoint's available, and I'm sure if anyone wants it, as long as if you want to use it, just say it's Matt's, and that's fine. This by one of our colleagues from across the ditch, Wayne Naylor, who's a fantastic palliative wound care nurse. He's done a lot of good pain. But basically, look, this is the implications of a fungating wound. It's not just the smell or the bleeding. Anatomical location. The face is different to a breast lesion. At least with a breast lesion, the majority of the time you can cover it up with something. The face is extremely hard to dress, extremely hard to cover. Would that man go outside? Would he go down the road here for a cup of coffee? Would he want his family to come in and see him? His friends? These are the things we need to think about with this. Comfort of the dressings is one thing. Sometimes you do this wonderful dressing, say a lady with the breast cancer, and she looks like this. We've puffed her out like this. What are people going to do? We feel great, we've padded it up, it looks really fantastic, we've got it to work. What are people going to do? Stare. Why have you got a third breast? What's going on under there? Staring, thinking. So sometimes when we do a dressing and we think it's fantastic and wonderful, have you taken into account how it's going to affect your patient? Can they still move their arm to have their cup of tea? What can they do? What are people going to do? Fear, embarrassment, depression, denial, self-respect, self-esteem. Who's heard this thing? My God, what stinks? Did a rat die in here or something? At the nurse's station. We're louder than we think sometimes at the nurse's station. My favourite one is the ward clerk generally doing the ninja with the smelly spray, the air, you know, if you've got it in a squeegee bottle or the aerosol, walking past doing this one, doing the ninja behind the back. You think the patient doesn't notice? You think they're stupid? What if we went up to them and said, look, there's a bit smelling here, do you mind if we spray this? Yeah, please, thanks. You don't think they don't know it smells? It's little things like that. Respect for their self-esteem, for their self-respect. Okay? What about the family? Cancer's scary enough, let alone when you can see it, smell it. How do they cope? They generally get denial. They generally say, surely you can fix this with your dressings. Surely you can do something about this. Why can't you do something about this? What about pawpaw, manuka honey? Surely you can fix something. Our obsession with putting condiments on people, I have no idea. And salads. So I could be a pawpaw on that. That'd be great. Put it on my salad, thanks. Don't put it in my wound. It can be very difficult. So sometimes you also have to manage the family more so than the patient. And again, this education, this concordance, letting them know what's going on, what we're doing. So goal setting for wound care. So we need to know where we're going before we choose a direction. Then we need to know if it's possible to get to the destination. So are we going to wound healing? Can we get there? No. Okay. Wrong destination. Wound management, can we get there? I think we can. Let's figure out the direction. So it's wonderful to have these big goals, but you have to be realistic if you see if you can get there. And those goals can change. Patient's condition can change. You can be wound management one week and wound healing another week. But that's why when we ask you to do a wound assessment, it's not just a one-off assessment. It's every time you do the dressing, you're doing a wound assessment. Okay. Common goals for wound care: wound healing, odour control, exudate management, pain control, debridement, edema management. This is a rather big and nasty malignant wound, isn't it? What do you think is a common thing people will say about this wound? Have you heard this one? How did they let it get so big? Why didn't they do something about it? She'd had this for 4 years, this lady, and she didn't see a doctor. Why? At the same time her husband was diagnosed with leukemia. She decided to dedicate herself to him. They were a madly in love couple. In fact, when he passed, she passed about 6 weeks after he passed. And she was doing better than him. But that's why she did. We don't know everybody's story, yet we're often quick to judge. How do they get there? Well, she loved her husband so much that she put him first. Whether we agree with that or not is not up to us, but that was her decision. She made it. Okay? But issues for her was weight on her breast, heavy dressings. I would have loved to use a range of dressings on her, but they were just too heavy for her. So we used dressings that I don't normally use a lot of. We used Bactigras, which is basically Gelinet with chlorhexidine, and just combines, and wrapped it over with a Tubifast, chest Tubifast. And she was happy with that. She could manage that herself. Is it ideal dressing that I would choose for her? No, but it worked for her, so we did it for her. So some palliative care specific goals: prevent pressure ulcers where possible, avoid infection, prevent deterioration in the wound, promote patient comfort, reduce caregiver burden, heal the wound when appropriate. So if you've got other skin tears are often associated with palliative wounds or any other type of wounds, maintain optimal functional capacity of the patient. Again, so don't dress them up so they can't move. Okay. Here's a nasty one for you. It's a homeless chap. And these little friends in here, maggots. We didn't put them there. He brought them with him. And actually, just recently, you had another chap with almost exactly the same wound come in. So, these things are devastating. This is one of my patients. She was an old nurse from St George. She actually did her training at St George and spent her time in the St George nurses' home. And she used to tell me how after night shift she'd go up to the roof of the nurses' home, smother herself in olive oil and go to sleep on the roof. We wouldn't do that today with our slip, slop, slap pads, but the fact was that education wasn't around then. And she'd be up there with 3 or 4 other nurses. So she's got this ulcerative wound on her neck. Just give you a little bit of anatomy revision here. This is why we don't just think about what dressing to put on that. What are these lovely blue and red things? Veins and arteries. So what's that going to hit? It's going to hit a carotid or a jugular, and she's going to bleed out. So the cancer's actually not really affecting her that bad. She's got an unknown primary, but one day that those vessels are going to rupture, and she's going to die. So some advice we give her: black and brown towels in the house. Why do you think black and brown towels? Somebody's going to find her. That's the reality. Somebody's going to find her. And what if I've got white towels and I'm putting it over there? I'm going to have bright red blood. It's going to be like a scene from CSI. But what if I've got black or brown towels? It's not as bad. It's still there, but it's not as bad. So this is advice we give people. This is advice we have to give people. It's not a nice conversation, let me tell you, but this is advice we have to give. We also provide what we call crisis kits, a mix of morphine and midazolam in a preloaded syringe. So when this happens, she can inject herself, so we have to train her to inject herself so that she can go. Because could you imagine the fear again? And she's a trained nurse. She understands, which makes it worse. Lovely lady. She's still with us, thank goodness, but the wound's just getting bigger and bigger. And how about dressing that? How do you dress that? This is Australia. What about a 40-degree heat? You're going to have a scarf on to cover that for dignity? Dressing the neck is extremely hard, and there's quite a bit of exudate coming from there. So what we had to do for her was we packed it with Aquacel, soak it, and at the time it was Allione we were using, but now it's Biotane Super. Biotane Super we're using it because it's nice and conformable to the neck, nice and thin. Uses nappy crystals. Huggies is the dressing world. But it was nice and thin for her. It was conformable to the neck, but very hard place to dress. We went through a number of different experimentations to get to that state. So some product selection. Factors influencing product assessment, product selection, always your wound assessment. If you don't know about wound assessment, get someone to give you a really good talk on wound assessment or come along to the College of Nursing and we've spent 2 days teaching you about wound healing and wound assessment. If you've already been to the College of Nursing, you would have seen me there teaching you this. Inpatient or outpatient status. It shouldn't matter, but it does. We can make morphine gel up at St George, morphine gel 0.1% mixed with solicite gel for about $3.50 You get that outpatient, $50, $100, because you've got to get it through a compounding pharmacy. And there aren't many compounding pharmacies left. And those that do, most often don't have a Schedule 8 area. So it puts the price up. Cost, it shouldn't matter, but it does. Okay, because at hospital, when you're in a hospital, I don't care, I'll put whatever dressing I have on you. I don't care if I have to order it in, I don't care how much it costs. If you need it, it's going to go on you. But outside, it's different. Okay, it depends what you have, what's available, where you're going to get it from, how much does it cost. Don't get it from the pharmacy, because each dressing will be about a 300% markup. Better places like Bright Sky or Independent Solutions are much better to go through than a pharmacy. Okay. So pain, morphine gel is quite contentious, and you have people for and against it. The literature I've read supports the use of morphine gel. There are some arguments that there's an uptake to the renal system, but I've seen papers that have said that that's not the case as well, that are equally well written as the papers that say you have an uptake of the morphine to the renal system. And at the end of life, we're generally not considering that anyway. But most of the literature that I've read shows that it's only a very superficial effect to the morphine gel. In fact, it's still wondered if it's placebo or not. But I find a very good effect with morphine gel with our patients for the pain. The issue you have, inpatient is cheap, outpatient is expensive, can be hard to get as an outpatient. It's not good for wet wounds. Why isn't it good for wet wounds? Why isn't a gel good for a wet wound? Yeah, what happens if I add something wet to something that's wet? It gets wetter. And so you're going to go, aha, I'll put a foam on top of that, or an Aquacell or a Combine. So your foam and your Aquacell's pain-free, because it's full of morphine, but your patient's not. Okay. Also, what if I've got necrotic eschar? Do you think the morphine's going to penetrate the necrotic eschar? No. But we have found if you put it at the wound margins, there is some pain relief. But again, you'll find lots of arguments for and against morphine gel. It was created at Calvary Hospital, just down from St George at Cogra, and many hospitals have taken it on, but many equally haven't. It depends on your anaesthetist and your anaesthetist's opinion of that form of pain relief. Odour, I won't go too much because Gary's going to talk about this. Things like Carboflex, I'm not a big fan of Carboflex and carbon-based dressings because you're adding a layer to the dressing. So you're making a bulky dressing already bulky. Also, who's seen the little carbon filters on your stoma bags? You seen the carbon filter on a stoma bag? Well, sometimes they have a carbon filter on the stoma bag to filter out the farts. All right? What happens when the carbon filter gets wet? Bag blows up and you get a code brown. Okay? And I'm a CNC, you know what CNC stands for? Clean, no crap. I'll be back in half an hour, sister. I've got another patient to see. Then I'll leave you to tidy that up. I'll be back in a minute. So as soon as the carbon gets wet, you decrease the effective odour control from it. So I'm not a big fan, but it's often used. Flagyl gel is often our first point of call, but if the bugs in the wound aren't susceptible to flagyl, you're still going to have the smell. Silver dressings, every company out there I bet you has got a silver dressing. Mark up the price of the dressing, 400% minimum. Okay, but think kill the bugs, kill the odour is my rule. Kill the bugs, kill the odour. I generally like to start with the Prontosan clean and then use something like a silver or any type of antiseptic to decrease the bioburden. Medi-honey, again, it's a good antiseptic. The Prontosan we just talked about. Aromatherapy, I'm not a big fan because you're just disguising the odour. Plus, the people who smell that will associate that odour with that wound for the rest of their life. So you imagine thinking of mum's big malignant wound on her face and you're burning eucalyptus oil and you're walking through Sydney in summer. You're smelling eucalyptus. It's hard. Okay. Generally prefer a non-adhesive dressing, such as Mepitel or any of the Ergo products. Anything that's non-adhesive, we really prefer because anything that sticks, your wound's going to bleed. And then getting hemostasis is extremely hard in a malignant wound. Wear time, 10 to 12 days, can be expensive. Not as expensive as you really think though. If it's in the bin after 2 days, it's going to be expensive. Okay? If it stays on the way it's supposed to stay on. Something like Mepilex Border is quite a common product we use, but there's lots of silicone foams now. Every company has a silicone foam. Ergotool is a good choice as well. Lipoido-colloid technology, a little bit different. Ergocell, again a different brand. Alleven Gentle, different brand. There's also Alleven Life now. Atramin or Adaptic, things like that, quite simple way to start, but they can stick. AquaClear is one you don't see anymore, a clear site. It's basically a solicite gel in a hardened form. It's quite soothing to the skin, it's quite cool, and there's some documented evidence of reducing the amount of pain relief required for this. My issue with it is you need to use an adhesive to hold it on. I find I use this more on staff than I do on patients. It's very good for hangovers on your eyes, and it's very good for blisters on your heels. So if you've got new shoes, ladies or gents, that's very good, but you have to use a very strong adhesive to hold it on. That's my main issue. Vasgauze, I'm not a fan of Vasgauze to start with, Crapanet or Gelanet or whatever you want to call it, large weave Vaseline, mainly because it macerates good skin. Why? The Vaseline, do we just evaporate fluid out of our body through our kidneys? It goes through our skin as well. So if I've got Vaseline over it, is the skin going to be able to? No. So you get maceration at the peri-wound edge. Large weave granulation can go through it if it's left on for too long. And you can granulate a wound, gelling it into the wound. I've lost count of the amount of times I pulled Gelanet out of a wound. But is that the product's fault? Here's a question for you. Is that the product's fault? No, it's the person who put it on. If you've left it on for 7 days and it's stuck, is the dressing going to say, well, actually, I'm about to get stuck, I'm going to pop off now? No. It's the nurses who are looking after it, or the medical staff who are looking after it. If you're leaving something on for too long and it's not worked, or you've not left it on long enough, it's not the product's fault. It's the person who's looking after the product. Okay, we like to blame the products a lot. That's why you have favourites. I know you've all got a favourite dressing. No matter what wound, that's the first one you go to first. Yep, because it worked really well that one time. All those laughs. You know it's true. Absorbent dressings again, so it's really oozy. Alginates are where we started. I remember when we used to lock these in the S4 cupboard because they're expensive. They've got what we call horizontal wicking, so when they draw the fluid up into them, when it's full going up, it will then draw sideways. So it ends up on if it's on the peri-wound, you'll get some maceration. Also, I find alginates form a big ball of snot and they fall with gravity. So if you've got a belly wound and you start off with it up here, I guarantee you by the next time you do the dressing change, it's in a big ball down the bottom. Okay, and the rest of the wound's uncovered. But it's good, it has some hemostatic properties if it's a calcium alginate, because calcium's part of your clotting cascade. If it's not a calcium alginate, if it's just an alginate, there's no hemostatic properties. Okay. Foams, every company's got a foam. $90 million industry in Australia, every company's got one. A foam is a foam is a foam is a foam. Okay? I hear the chorus from the back. No, it's not. Well, it is, I'm telling you. Okay? Low cost, horizontal winking may indent into edematous wound, so if you're putting compression on, it may push into the edema. When you pull it off, you've got a lovely foam shape in the patient's leg. Mild to moderate exudate, low adherence, wear time 3 to 5 days. But on the pain scale, there's also Biotane IBU, which is very good for malignant breast wounds. We've found at St George for pain, for those wet wounds. So the wet wounds go into the Biotane and activate the ibuprofen, which then goes into the wound. We had so much success with it. In fact, one man worked a third job so he could pay for his own dressings for his wife when they left the hospital. It was so good for her pain relief. So Aquacell, they do now have Durafiber, and Monlica now have their own version. They can't call it a hydrofiber, they're not allowed, but their own version of a hydrofiber. I'm sure they've got it out there for you to see. Low to moderate price vertical wicking, so you don't get that horizontal pull to the sides. So this is one of my primary dressings because it's low profile for the malignant wounds. It's very low profile, so it's less bulk. When it turns, there's enough exudate, it will turn to a gel, so it will come off easier. Sometimes I'll combine it with the Mepitel, even if it's still sticking. I'll put the Mepitel down first, then the Aquacel. Just combine the products just to see what works for your patient. Durafiber is Smith & Nephew's version. Secondary absorbers, Mesorbs or Zedivits are very good. One Mesorb or Zedivit will give you 5 combines worth of absorbency. Okay? And they're only about $1.20. Good combination is Aquacel and Mesorb or Aquacel and Zedivit. So, Desi, I haven't renamed it, I'm sorry, Collar Plus people. I still remember it as Allione, but it's now Biotane Super. Okay, moderately priced, high exudate, comes with an adhesive, non-adhesive. Why I'd wanted adhesive, I'm not sure, but the adhesive one did work well for that lady's neck. Bleeding wounds, sometimes we go far enough to use tranexamic acid paste. Generally through St George, we do this through our palliative care nurses. Tranexamic acid capsules are crushed and then mixed with a solicite gel to put on the wound. But these can take 2 days to kick in. So you won't get the bleeding stopped immediately. You won't get immediate hemostasis. It can take up to 2 days to kick in. Adrenaline, sometimes we'll put adrenaline straight onto a wound, irrigate it over a wound, but you'll get an ischemic eschar. But sometimes that's what we want to cause that hemostasis in the wound. And you can mix it into a gel as well. And we get references for those so inclined. I do recommend anything by Diane Langemo. She writes fantastic articles on palliative care, end-of-life care, particularly skin failure, where the skin fails as an organ, particularly towards the end of life. Thank you very much.